Good evening. Welcome to another episode of Innovation on the Loose, streaming from the DeBakey CV Education studios at Houston Methodist Hospital. Tonight, I'm delighted to have in the studio my special guest, Dr. Ferdinando Rodriguez, all the way from London. He's a professor of medical robotics in the Department of Mechanical Engineering at Imperial College London and co-director of the Hamlin Centre for Robotics. And he's here tonight to discuss robotic assisted orthopedic surgery, and in particular, his personal account of the Acrobot story. Ferdinando, pleasure to have you on the show.
Thank you, Stuart. I'm delighted to be here. It is a privilege to be a guest on your show. And importantly, it is a pleasure to take a moment to share this unique story of early surgical robotics in the context of orthopedics, where I was a fledgling young PhD student working with the team that brought the first robot for unicompartmental knee arthroplasty in the world, all the way from bench to bedside with a clinical trial. Now, back then, and in fact, in many ways today, the majority of orthopedic surgical equipment is made up of jigs and fixtures, oscillating saws, so mechanical instruments that a surgeon uses to place cuts on the bone, to place an implant in the right position and orientation. And what is true about the technology you see on screen, it is that it is not very quantitative and repeatable, which basically means that the surgeon that has a significant amount of experience will tend to do better and place the implant more accurately and more precisely than a novice surgeon who has only had few experience in the operating theater. And of course, that was the starting point of the Acrobot journey. How could we make this process more precise and more accurate? And of course, if you take conventional instruments at the starting point, you can imagine that using computers or computer-aided surgical system can add an element of accuracy to the operating theater by having a system that in many ways acts a little bit like a navigation system, a Google Maps for the operating theater. Now with navigation, you are basically endowing instruments with optical trackers and the patient with markers, such that the system can then tell the clinician where one is with respect to the other, and in so doing, lead them in the right direction. So the type of a system of a CAS device in orthopedics is passive, as in is only having a screen telling you where you are supposed to go, but is not making the surgeon do a better job. And that is where robotics really comes into its own. You can imagine a robot a bit like a superset of a navigation system, where not only do you have a computer and trackers to tell you where the implant, where the instruments, and where the patient are, but you also have an active tool, a robot, that guides the surgeon hand in pursuit of a more accurate and more repeatable surgical outcome. Now, of course, we had this original story back in the day. We're talking about the late 1990s and the early 2000s, with a system which was the very first in orthopedics to look at this cooperative form of assistance of a robot in surgery. What do I mean by cooperative? I mean that in the good old days, you could have a robot that you'd press a button and it would do the procedure, or you could have a robot that you'd press a button, place a jig in the right place, and then stop, so that you could do then the procedure manually through a particular fixture. The cooperative approach of Acrobot was unique in that you wouldn't have either one or the other one operating separately from one another, but actually the two working together. A bit like working within the context of a three-dimensional protractor. Within a three-dimensional region, the surgeon would be able to paint bone away freehand, but as you reached the boundaries of this region that define the amount of bone to be taken away, the robot motors would engage, preventing you from overcutting. We called it Acrobot, or active constraint robot, for this matter. Now, if you look at the workflow of that robot, if in 2000 it wasn't really very much different from what it is today. There was a preoperative planning phase, which was the part of the procedure where the particular surgery was planned. You had an intraoperative step, which is basically the robotic assisted set of cuts and implantation of, in this case, a unicompartmental knee implant, and then a postoperative phase, which was necessary to evaluate what the system did in the context of that surgery. Now, there are two types of systems in this world, image-based systems or image-free systems. Image-based systems use images acquired of the patient prior to surgery. Image-free systems build a model of this plan directly in the operating theater. Acrobot was an image-based system that used CT scans in order to create a patient-specific plan of the surgery. So we started with CT slices, which, as you know, are like a stack of two-dimensional cards that represent the anatomy, and through a semi-automatic process, we segmented each one of these slices to produce a three-dimensional anatomical model of the patient in question. We then drew lines defining the mechanical axis of the knee from the hip to the knee to the ankle to redefine this sort of straight line connecting the three, which is basically the purpose of an arthroplasty procedure of the knee. Now, on the back of that particular plan, you can then create a set of constraints, that's what we call them, basically this idea of a three-dimensional boundary that would tell you what cuts you had to place on the bone in order for the implant that you're planning for to sit in the right position and orientation to reconstruct this straight axis between the hip, the knee, and the ankle. Now, the bread and butter of the system is obviously the intraoperative setup, which obviously is not only the robot, but is everything that went along with it. First and foremost was the idea that from the plan, where you had the procedure and the volume of cuts carefully defined, you had to create constraint boundaries, which then the robot would follow in order to prevent you from overcutting. And what you see on screen is these boundaries for the femoral bone and for the tibial bone, which of course constrain the electrical drill that we use to machine the bone away to a safe region. So then we go to the intraoperative process, which was basically a fairly convoluted setup compared to what setups you'd have now in 2023. And that was predominantly because in the early 2000s, the computational power, or the computational engine of the robot and the computer were a fraction of what they are now. And so there wasn't an ability to track the position and orientation of the limb of the patient in real time without causing instability and thus a risk to the patient. So we had to pin the limb to the ground. In fact, as you see on screen, we had a set of telescopic rods that would basically percutaneously mount onto the bone and clamp the limb with respect to the operating table to create a fixed relationship between the robot and the patient. And once we did this, we could go in, perform this process called registration, which is in fact the process by which you tell the robot where the patient is, and that was pretty much the crux of my entire PhD in the early 2000s. And finally, we could get this cooperative machining of the bone, which you'll see in a video rendering in the next slide. Now clearly, once the cutting was complete, you'd go on and implant and close exactly as per conventional procedure. Now, the video you see in this slide exemplifies this idea of cooperative control. So you see the surgeon hand, which this is a surgeon hand of Johan Henkel, who was my partner in crime in those early days. So the clinical research fellow that pretty much spearheaded the logistic of running our very first clinical trial, painting the bone away almost freehand. And of course, that gave you the possibility, as you see here, of inserting the implant as snugly as possible within the cut that you've made in the femoral condyle with extreme accuracy and precision with respect to the plan that you had produced prior to surgery. Now, of course, that is what we expected, but back in 2000, there wasn't a real way for us to measure the accuracy and precision with which we did this process. And that is predominantly because back then, and in fact now, the majority of assessment is done with X-rays. Short film X-rays, as you see on the left, or at the very best, long-standing X-rays. And we know full well, without having a technical background or a clinical background, that X-rays suffer from a number of shortcomings. They suffer from perspective distortion. They suffer from the fact that depending on the orientation from which you're taking the X-rays, you may get an artifact in the way that you're measuring the angle. So there we were, building a robot that could be millimeter and degree accurate, hoping to measure the difference between a robot and a human operator using jigs and fixture with X-rays. And of course, that wasn't good enough. And so we were the very first worldwide who decided to take a leap of faith, and really sort of, I would say, wash our clothes in public by taking quantitative measurements of the patient prior to surgery and post-surgery using CT. So what we ended up doing, and this was something that we did first and has then been adopted and used by many others from the 2000s onwards, is to take a preoperative CT scan on which you'd plan the surgery, and then take a subsequent post-operative CT scan after surgery, where of course you'd had the patient's anatomy that hadn't changed, but in the post-operative CT you also had the implant clearly visible once artifacts from metals in the CT were suitably removed via complicated image processing. And so by marrying the anatomy of the patient pre and post-surgery, you could then compare the position of the implant to the plan with unprecedented accuracy. Not like an X-ray in 2D, but in full 3 dimensions with 3 degrees of position, X, Y, and Z, and 3 degrees of orientation. And it is thanks to this setup, which we could do without endangering the patient by creating a very an optimized CT acquisition protocol specifically for the knee, which was published. In fact, Johan Henkel was the primary author, and it has been referenced many times since it was originally published. With that protocol and this pre-post CT, we went on and did our randomized clinical trial. Right? As you can see in this picture here, you've got the geometry of the implant, and then the actual implant segmented out of the postoperative CT. And by bringing those two into alignment, you could get this sort of full pose estimation with millimeter and degree accuracy. And so, strong of the protocol and the system, we created a randomized control trial of human surgery, or so classical surgery, arthroplasty done by surgeons doing their best, and robotic surgery. And then, of course, for each one of these patients, we had this particular outcome, where you can see in gray is the planned implant position, and in gold, you've got the achieved implant position. And of course, by comparing the difference between the two, you could get full pose estimation without any X-ray artifacts. And what you see here, in fact, is some of the early work, both in the plastic bones. Yeah, you can see it. Where are we? Can you see it? Not quite, it's not working. So it is Johan Henkel working on plastic, and then of course on the left, some of the very first clinical trials. So we did something like 13 versus 13, conventional versus robotic, and the results are here on screen. You don't need any complicated statistic to see quite unequivocally that the amount of difference between gray and yellow on the left-hand side is significantly more than the amount of difference in the right-hand side, which was robotic surgery. And that unequivocally demonstrated that with a robot you could be much more accurate, which basically means a smaller difference between yellow and gray, and much better repeatability, so smaller accuracy or better accuracy across our entire cohort if we use the robot. This was a landmark publication that we published in 2006, and basically then gave us the springboard to commercialize the system and then evolve its hardware. Now, in 2000, when I first joined the project, the system looked as you see on screen. It was an incredibly bulky robot, which was made in the labs and the workshops at Imperial College London, and it clearly was not suitable for prime time, but it was accurate enough to take us through cadaver trials. Now, since then, we evolved it so that by 2012, it was the system that you see in the middle, much refined, without a gross positioner holding us back, and with a much more streamlined end effector. And it is this robot that came out of Acrobot Limited, a spin out of Imperial College, and was purchased by Stanmore Implants Worldwide, who then spent a couple of years gaining CE marking and FDA approval. Now, it is at this point that Stanmore Implants Worldwide brought the system to be showcased at AAOS, the American Orthopedics Association, and it is soon after then that through litigation and some less than pleasant aspects of that commercial process, Mako acquired the rights to the Acrobot system. So we would say that at least the Mako system, which was an orthopedic robot for arthroplasty, which is now part of Stryker, the soul of Mako is also somehow, has also absorbed the Acrobat Story. So I wouldn't say that it was necessarily a commercial success, but it certainly was a mighty technological success, and one that I was privileged to be a part of, in the journey from bench to bedside, and it undoubtedly informed my career to date. Now, I am delighted to be able to have a presentation like today, like this today, because while 10 years ago the commercial landscape in surgical robotics was very different from what it was now, today, as you can see, we have a number of significant acquisition of smaller fledgling robotic companies by larger corporate entities. We've got the Mako Stryker story. We've got Mazor, an Israeli company that was bought by Medtronic. We've got Navio, or Bluebelt Technology, which was a spin-out of Carnegie Mellon University, which was bought by Smith & Nephew, and so on and so forth. So finally, in 2023, we have a plethora of commercial systems backed by large companies with significantly positive balance sheets that can push us forward. Now, that's the positive. The reality is, as of today, there aren't robotic systems, at least not in orthopedic surgery, in every operating theater worldwide. And that is clearly the next big challenge for us as a community. How do we make this robotic system more accessible and more ubiquitous, and certainly more widely impactful? And for that, the barriers that stand in the way are both technological and non. The non-technological barriers, how accurately and how we integrate the systems in the workplace represent a question that we have to solve with clinicians. But then there are technological reasons or technological challenges, which is what we've been focusing on at Imperial College in the Hamlin Center and my own Mechatronics in Medicine lab. And I think in that context, the future revolves around three main advances that all help to create devices that are a little bit better suited for the intended purpose that they have. We're talking about devices that are smaller, cheaper, more compact, so smart information delivery systems. And then, of course, systems that are a lot easier to guide through the complex workflows of surgeries. And some of the work we're doing in this space are maybe the subject of a different presentation. Just to end up, there isn't a better time to be a surgical roboticist than now. The accelerated progress on every facet of technology, from software to hardware, machine learning, the British Public Health Service, but the digitization of health, which is true in the US as it is in the UK, and of course the access to hardware and software are making progress in this space the fastest I have ever witnessed from my research days to my academic leadership days. And so if I have any comment in this space, is there wouldn't be a better time for clinicians and engineers and scientists to join this particular health space. So with that, I would like to thank obviously all of the research that I work with on a day in and day out, and the many sponsors that support the research that I've done over many years, and remind everyone that we run, similarly to Houston Methodist, a yearly symposium which usually happens late in June, and it is an opportunity to see some of the very best in surgical robotics and allied technology space gathered under one roof. And with that, I'd like to take the opportunity to thank you again for the opportunity to speak. Thank you, Stuart.
Thanks, Ferdinando. And I would advise the audience, if they can, to make it to the symposium next year in London. I had the honour of going this year and it was fantastic, so really put it on your schedule. So I got a few questions here. So it's funny, you're talking about late 90s, early 2000s. It reminds me of, Britain at that time and stuff. And, with your PhD project, was the project already there for you to kind of get on straight away and kind of solve, or did it grow organically out of activities?
Yeah, it is a story I've told pretty much each one of my PhD students. I did my PhD retrospectively because I joined Imperial College as a PhD student under Brian Davis, my PhD supervisor, in 2000. And I did it because I felt I was a little too young to go work, and I wanted to just study and learn and play a little bit longer. And then I was lucky to join this tiny little team that was just about to get into the most exciting part of robotic surgery development, because basically I joined with the very first cadaver trial, and I finished my relationship with them having completed a full-blown human trial, right? And so the focus throughout my PhD was debugging, problem solving, babysitting systems in the operating theater. We were in the hospital, in the operating theater every day, multiple times a day. There was enormous amount of stress and reward and team bonding and camaraderie. And then I got to the end of my PhD. I had to sort of think about how to put it together in a coherent fashion in order so that it would have this sort of start, middle, and an end that you'd expect of a PhD. So absolutely organically, but with a significant amount of retrospective analysis of what I had done so that it would fit a narrative that was commensurate to a thesis.
So you talked about the randomized clinical trial there, and where was that done?
It was in a single hospital. Basically, it was a hospital associated to UCL, which is basically where the clinical lead, Professor Justin Cobb, was working at. In fact, that hospital, it was called the Middlesex, doesn't exist anymore. They made flats.
Right. Oh, wow.
Yeah.
I know we talked about a little bit about this earlier, but do you want to compare the landscape and the ability to do a randomized human clinical trial back then versus now?
So I think it's fair to say we could get away with things back then that I am not sure you could get away with now, given we are on a live audience and this will circulate the world. Everything was done by the book, hand on heart. Yeah. But I think for the times, I think bringing something as complicated and nuanced as a robotic system in an operating theater required a lot of judgment. So the surgical staff, the nursing staff, the hospital were unclear about the ins and outs of how a system would operate in the operating theater. And so in a sense, it gave us a bit of an accelerated route to a clinical trial. I think it will be more complex now, right? Yeah. But it's also, there's a much better carved path to follow than there was back in 2000, certainly in the UK.
And I do believe I heard stories, if you go back even further to like the 50s or 60s, you hear stories of surgeons on a Friday having a problem. They go home to the garage, come up with a device, a cutting tool, use it on a patient on a Monday.
Yeah.
So it's constantly evolving, right? The procedures and the protocols, etc. Yeah. So a bit more of a broader kind of questions now. So what do you feel are the current clinical challenges that robotics and robotic platforms are going after?
Yeah, it's a very good question. So I think we've sort of reached a level of maturity with the technology whereby I am not sure the technology is the bottleneck anymore. I think at the moment it is the duty of our community being made up of three main parties. It is the scientists and engineers that build the tech, it is the industry that commercializes the tech, and it is the hospital and clinicians that use the tech, right? I think together we must figure out now how to bring this technology to prime time. So I would say that the great efforts performed to date by all roboticists that have created the technology that have subsequently been acquired by the big corporations, they represent the mid-level of maturity that would allow us to garner the clinical evidence on which the robots that will make it into the major leagues will be built from, right? So I don't believe that any of the robots today are the robots of the future, but I do believe that our duty now is to take these robots and work with clinicians and industry to try to understand how to better integrate them into the workflow of surgery. Now, I always say this. I think in 2000, we were sort of trying to figure out what might help. It was very much an example of a technology push. A few enlightened clinicians and a lot of hardworking scientists and engineers trying to pursue a system that they thought would be useful. We now have to build the broader evidence the clinical pool that then carries the system into say basically into mainstream.
And do you feel that, I mean, it seems to me that there's been a massive, over the last 2-3 decades, it's all about robotic assisted surgeries, right? So robots in the OR. But if you look at landscape now, the patient journey, it's so much broader than just being in the OR. So do you feel there's a kind of an area for that robotics can interplay, like outside the hospital, in the home, in outpatient centers, that type of thing?
Absolutely, yes. And if there was one epiphany of my journey in this space over the last few years, it is that I spent the early part of my career thinking that the hardware of these robotic systems in surgery and outside was the bottleneck, right? So moving from classical serial hard manipulators to something more dexterous and maybe soft and compliant. But in reality, what I have seen happening with machine learning and the ability of software to really understand and map what is possible and what happens in a hospital environment has now opened my eyes to the fact that getting the system to perform better is also a question of trying to figure out what information is in their context that we can mine and then use to make the systems better.
Okay, got it. And I guess it ties up my next question a little bit. There seems there's a lot of robotic platforms out there, all different, all from different vendors, etc. Do you know of any kind of more platform robotic technology that could be used for multiple specialities, maybe by incorporating different types of software, etc.?
So the opportunity exists, but I am not naive to the fact that this technology takes decades and tens, if not hundreds of millions of dollars to come to production. And so if you are the company that built and markets the product, you have a natural desire to protect that intellectual property. And that basically means that you do have cross-platform or open platform systems for research, but you tend to have fairly closed platform system for, so that in your sort of industrial offering. If I had carte blanche, I would get companies to work together and develop cross-platform protocols that would allow us to take information from multiple systems, because that would accelerate progress inordinately. And I think there is some possibility that would happen in the right set of circumstances and with the right sort of engine behind it.
Okay. And I'm interested on technology, like technologies that are on the horizon. All right, so 2023, age of AI, right? But what is out there in the future? And maybe we incorporate micro-nano robotics into that. What are your thoughts on that?
So I'd say that there is a short to mid-term future. So unequivocally, if the 20th century was telecoms and automotive, the 21st century is health and care, right? So the progress we have made over the past 10 years dwarfs the progress we have made on the prior 50 years, right? So in terms of ubiquitous presence of technology, of this type of technology in health, that's undoubted. As much outside theater as it is in the operating theater. And in fact, I'd go as far as to say that I see a future before I retire where you'd have plenty of this technology in the home as well, right? Simply because it is the natural evolution of monitoring and health systems. Now, with micro-nano, which is one of the growing themes of the center that I co-direct, which is the Hamlin Center, that's the moonshot, right? In fact, I think if there is one thing that is still difficult to fully grasp, is quite the extent of the impact this type of technology, which, to be clear, is the development of robotic-like devices that are smaller than a fraction of the diameter of a human hair. So we're talking about very, very small things that can operate at a cellular level, right? The challenges, the technical challenges that stand in the way of making progress in this space are many. We've just recruited academics in this space to try to explore this sort of nascent new field, but to see what the tangible clinical impact it will have in the short to medium term is very, very hard.
Yeah, because I mean, I've seen a lot of nanotech out there would have been like using external magnets, electromagnetic sources to steer, ferrochrome, iron oxide nanoparticles. Then there's usually a theragnostic component, right? So they kind of they diagnose, but also treat whether it's thermal or not. But then there's the whole classic of it's like a miniaturized little actual robot. But is there any other types of areas which are being explored?
So it's certainly diagnostics and therapy, from single cell manipulation to the targeted deployment of chemotherapeutics or other drugs directly to the site. It can be used alone, and alone I mean you could basically use a magnetic gradient to direct small particles to the right place, or they could be used in conjunction with a minimally invasive approach that takes you to the, let's say to the broad postcode of where you want to be, and then you just do the last mile with a different technology. Now, the reality is, if I play devil's advocate, it's still very much a technology push, right? It's still very much curiosity-driven science and engineering, where there is a tenuous link to a very clear clinical need, but there isn't a strong one. And I think it is where robotics, for example, which is more my bread and butter, was 20 years ago, and now I think we have a duty of care to turn it more from a technology push to a clinical pull. And I think the robotics at the micro and nano scale will go through the same journey, and in the not too distant future, as we identify clinical problems that really are ripe for solving with these new miniature technologies, then I think it will also change the way that we approach it.
Okay. Now, going back to your last slide, I know you had there, you were very excited about current state of affairs in regards to all the robotic technology, and it seems that there's a lot of tech out there, but the time frame to market, it's still kind of, you're looking at 5 to 10 years, etc. So
optimistically.
So that's optimistically. So I mean, again, it's like, okay, there's more tech out there, but you still got the bottlenecks. So how are people really filtering out and choosing the best tech, or is it really just being pushed by the big conglomerates like the Googles and the Amazons, etc.?
So it is a mighty difficult question, right? I have been part of a small company. I have also seen many other small companies succumbing to the market pressure and their inability to raise sufficient fund to make it into the main leagues. And I think the only way to overcome this is through major partnership and acquisition with large companies that have got revenues beyond what they could possibly get with the new technology. So the problem with that is it comes at a cost, right? And so you cannot point the finger of big pharma or corporate because they are not sharing, because ultimately they have shareholders and they have to protect the investment they have made. So in a perfect world, there will be mechanism whereby smaller companies can find their feet and are supported to create diversity in the marketplace. But in the real world, it is a very, very hard business, and I think health tech is particularly hard, because the route to market is very long and windy, because the regulatory framework, in Europe we had this big change with the medical device regulation, so MDR, which has completely shake things up. And it means that if you are the small company who has a small amount of runway with their funding, it is very difficult to get a system to market these days.
Okay, so it seems like it really does a little bit, the business model needs to kind of change. Okay. Well, listen, it's been an absolute pleasure having you on the show,
Stuart,
Ferdinando.
it's been my pleasure.
And again, I'm glad you're enjoying your stay in Texas so far, in Houston. And thank you to members of the audience for tuning in, and we look forward to seeing you in the next episode. Goodbye.
Thank you.